Members were interested in learning more about planning, implementation, and evaluation of specific food as medicine programs. Today, we are excited to welcome Dr. Hope Galvan from Harris Health, who will take a deeper dive into the Harris Health System Food Pharmacy, which has served over 6,000 patients and their families. Dr. Galvan will share the step-by-step process undertaken at Harris Health, including the challenges encountered along the way. She will speak for about 40 minutes, after which we will have 15 minutes for Q&A. Throughout the presentation, you are welcome to put questions, comments, or observations in the chat. We will address these during the Q&A session. Your microphone should remain on mute over the duration of the presentation, and during the Q&A session, you can raise your hand and we will call on you, at which time you can turn on your microphone to answer a question. Now, I'd like to introduce Dr. Hope Galvan, Vice President of Population Health Transformation at Harris Health System. As a board-certified cardiovascular nurse with over 25 years of experience, Dr. Galvan holds extensive clinical experience in inpatient and outpatient nursing. Through her clinical experience, she gained an understanding and a passion for holistic systems approaches to improving health outcomes for underserved populations. Today, she will share her lessons learned in launching the first multi-sectoral clinic-integrated food prescription initiative for food insecure and diabetes patients in the region. I'll pass it over to you, Dr. Galvan.
Good afternoon, everyone. First of all, I'm happy to see so many familiar faces because it'll be a friendly audience, I hope. But that said, thank you so much to the Texas Non-Medical Drivers of Health Consortium for the invitation, but most importantly for bringing us together. During the presentation, I am going to go off camera just for the sake of trying to keep distractions down. So bear with me a second as I share. All right. I see that the presentation. Can y'all hear me okay?
Yes.
Very good. All right. So we're here today to learn, as Jackie said, about a prescription to nutrition and how we integrated a food pharmacy into our clinical practice. And so one of the screen's frozen. Okay, I'll start with a little bit of background about who Harris Health is. We are the fourth largest public healthcare system, and our approach to care is a holistic and integrated approach as a system. We have community health centers, homeless clinics, same-day sites, multi-specialty clinics. We have a dialysis center, dental center. The community health centers, we have about 15. The pediatric and adolescent centers, we have about 2. 3 same-day clinics, and by same day, we mean the patient gets same-day services. With our HIV center, it's the nation's first freestanding HIV treatment center. It's now at Quentin Meese. And our homeless program has about 9 homeless clinics. The patient population that we serve and that we've served for over 50 years, as you can see here, we were established actually in Harris County in 1965 to provide the care for the underserved residents, right? We care for about 254,000 unique patients in 2020, but that number is still about the same. 54% of our patient population is uninsured, 90% communities of color. As a safety net, we have our work cut out for us. Our journey really goes back to learning very quickly who our patients are, who we serve. Being a safety net, we knew that our patients were dealing with a lot of life issues as it relates to poverty, one being food insecurity. We understood too that food insecurity impacts health. And I put this here because I think everybody in this room knows this, right? But I just wanted to reiterate that food insecurity is not a patient problem. It's not an individual problem. It's a household problem. And so what we see in our households is an increased likelihood of being overweight, obese, increase in prevalence of diabetes and other nutrition-related diseases such as heart failure, high blood pressure, high cholesterol. But for our patients living with diabetes, they're about 2 or 3 times have uncontrolled diabetes. And it's been well studied and well published. So we'll start talking about our journey. Our journey starts with 4 elements, right? We start with how did we even define the problem as part of conception? We had to go through a planning phase, an implementation phase, and an evaluation phase. When we started to look at our work that we wanted to do for food insecurity, we had to be very strategic in how we were defining the problem, the purpose of the solutions that we wanted to bring. How are we going to define the measure of impact? And we created a logic model that helped us with the organization buy-in. In the planning phases, once we went through this organization buy-in, we had to identify community-based partners who either had an interest or were already doing this work, defining our responsibilities as an organization, and part of it was funding, as well as our partners. Part of the planning phase also included, how we looked at our clinics, from the physical environment to the permits that we had to get to the equipment and supplies. And then how did we manage our food pharmacy site? The implementation phase was very much about how do we deliver this service not only to our patients, but to our frontline staff, right, who will be helping us through the patient referral process, through our daily operation piece, through our food inventory. And then last but not least, evaluation. What's going to be our approach to show that we're doing this for the right reason and that what we've done is meeting our objectives in helping our patients address food insecurity and nutrition security. So we'll walk through all of this today, and I'll start by saying that as an understanding, as an organization, and as a safety net for Harris County, this is our patient population, and it's probably the patient population of many of you in this room as well. In Harris County, and for our patient population, there was a high volume of uncontrolled blood pressure, uncontrolled cholesterol, uncontrolled diabetes. These are very much nutrition-related diseases that, we felt because our patients were expressing food insecurity, we needed to address these things. And so we went to the literature, first and foremost, as part of our assessment as well. We were screening for food insecurity. We were looking at our community, but we also needed to learn what was happening across the country. And so with that, we were very fortunate actually back in 2018, because, this work started in 2017. In 2018, the advisory board had actually published kind of a research that they had done on different programs across the country. So it gave us some direction. And so the recommendations here that you see were, things that we also took into consideration which was frame hunger as a healthcare issue, right? The screening that you're going to do for food insecurity needs to be validated, needs to have some sort of, process that is, end user friendly. We need to secure the leadership support and access to immediate assistance when maybe some of our internal partners find it difficult to work with us or don't necessarily see the importance of this. Clinician engagement, because at the end of the day, they're the ones who are taking care of our patients and helping us with the screening as well. And then the partnerships. I think for the partnerships, what we found very quickly is that, we needed to get strong organizations and set expectations. What was their role and what was our role? And the advisory board really helped us kind of ask these questions right from the very beginning, because they provided this great tool. And at the end of the day, they also spoke and recommended us to take on how do you create outcomes? And the outcomes that you create need to be created with a sense of, to help you sustain, to help you demonstrate clinical and value to utilization for this particular initiative. And so once we read the literature and did that review, we also went to have different conversations, because again, through the advisory board, them directing us to some folks that were already doing this work, in talking to them, they directed us to other folks who were doing this work. And so what you don't see on this list are folks like Geisinger, Eskenazi, CHOP, which is Children's Hospital of Pennsylvania, that we also had conversations with about what are some of these best practices, that are listed already out there. And really what we were the question that we asked each organization was, what was your focus? What are your lessons learned? What's your secret sauce? For instance, Boston Medical, you've been at this for many years. Like, how have you sustained this? And also, too, what were some of those key partnerships that we should be looking at? Because again, this is us going into something that did not exist in Texas. And so as a nurse, we also needed that direction, right, in our department. So what did we learn? We learned very quickly that in some of these organizations, they were like, you all need to consider how you're screening your patients. Is it paper or is it verbal? We'll tell you right now that the paper format is much better than verbal, because if you ask your patients, they're not going to want to tell you the truth for the most part. There might be some sense of fear, some certain sense of stigma. What we also learned was, for instance, I'll give you a quick example, ProMedica. They're like, we're using the hunger vital sign because it's easy to use. Everybody knew that it was probably not the best tool that was out there, but it was the tool that needed to be used in a fast-paced healthcare setting, and something that you could easily put in an electronic medical record, and something that the folks would be like, okay, that's not bad, 2 questions. And so those lessons learned and that secret sauce that some of these partners shared in organizations was very valuable to help us, create this model. And so as far as, I'm just going to kind of outline here, it really was about the research at a local level and a regional level for food insecurity that helped us make the need, right, the ask. And then assessing our clinic as well as our Houston Food Bank partnership data about what exists already out there for food insecurity. Then you look at your clinic volumes and your chronic disease prevalence, right? Because what we found is that even though we have 15 clinics sprinkled throughout Harris County, not every clinic is the same, right? Some folks are dealing with high rate of diabetes, while other folks were dealing with a high rate of asthma. But still, it's, nutrition needs to be considered for asthma, but we were targeting the diabetes patient population, and I'll talk about that more in a second. And then also something that we considered was we met with the clinic leadership about staffing, about space, and about their patient population. Because those folks in the clinic are there day in and day out. You don't want to bring a program to that says, here you go, put this up for me, like, let's get it done. No, it's like, what are you observing? What are you experiencing, clinician, nurse, doctor, medical assistant, lab, from your perspective with your patient population? And then from there, prioritizing clinics. And we do consider the leadership style of those clinics because, we want to make sure these programs are successful. And then propose the modality that aligns with the clinic. And most importantly is the training. Is that, okay, we learned that you are screening for food insecurity. You are excited. This is something that you want to do. But then we have to train them, because no matter how much you set up screening at a certain point in time for the patient, sometimes patients will connect with other folks throughout the clinic and express something to somebody else that they don't necessarily express at check-in or at registration or in the room with the physician. So we had to make sure that we trained everybody about how do you screen for food insecurity and why do you screen? Are you screening because we're telling you to ask a question? Or are you screening because we're going to capture data and then we're going to report back out to you and let you know what's going on in your clinic? And so those are some of the things that we kind of considered as we were building this out and actually put in practice. And so implementation with the best practice tool, as you can see here, this was the tool that everybody in the healthcare setting was very much expressing that, hope, hunger vital signs. There's a lot of opportunities here, right? But again, it's a start, right? Of where we need to go when we start screening. 2 questions, 2 easy questions. And so then what happens? The patient gets screened, but then we give them a food prescription, right? We had to give the patient something tangible that said, here, Mr. Galvan, you expressed this need. This is what we have for you. What you will receive, because you've expressed this need, is 30 pounds of food, education by a dietitian, and here's our hours of operation. We're here for you. And we're 200 steps down, like, come this way. Again, helping our patients, give them reassurance. I will tell you that when we launched this was in 2018 and 2019, and we got hit by COVID. Our model was patient choice. But I will tell you, with COVID, we had to go to virtual. When we went to virtual, it wasn't the, here you go, right? It wasn't the screening that we could do face-to-face, but we had to retrain our staff to screen for food insecurity, but now it's in the virtual world. And I stress the retraining because what I found was we launched food insecurity screening, we trained, but when I went back to go ask, hey, talk to me about how you're screening, it's like, oh, well, I'm just telling the patient I'm asking because I have to. It was like, whoa, lesson learned, right? It's not a one-time training, this is ongoing. And with that, as we look at systemizing our screening for those non-medical drivers of health, we already learned this lesson, right? So now we know that the screening training, the why, is an ongoing process. It is not a one-time annual thing, it's ongoing. And so the other thing that we learned as we were launching this and as what we thought about was, how do we get our providers engaged and make it easy for them? So of course we went directly to the EMR. Why? Because that's where they spend 99.9% of their time, right? And so gave them the tool, got input from them, wanted to know, if we put this in Epic, will you utilize it? And if you do, how can we make this easier for you? And what would you like to see? And what we got was, oh, I'm with you. We'll help you. Like, we know our patient population. But you know what would be great? If we could get a referral to the care management team as well. And so that's the feedback that you want, because we weren't thinking about that piece in the EMR. So they helped us with that. So we also learned that, you know, as we did the assessment, and part of implementation is that, you know, we have a national problem with food insecurity, and we have a local problem. You name it, we have it. We can't boil the ocean. So what is our approach? It's risk stratified. When we talk to different organizations, one of the things that I kept hearing over and over is like, Hope, unless you identify a population, you will likely lose integrity of your program, because you're not going to be able to show outcomes for a large group of people. So focus. And so with that, we talked with our partners, Houston Food Bank, and they're like, we have programs, First Link, emergency food distribution and nutrition education, and we still connect them to resources. But it's for those folks who maybe don't have a nutrition-driven disease, that, you know, we can provide that intervention. It's emergent, but they don't have the diabetes, the heart failure, and all those other things that, you know, that you're addressing. And so then when we went to the Food RX, we're like, okay, positive for food insecurity, but what's that chronic disease component that we want to add? Well, you want to add something like diabetes, because why? Diabetes comes with blood pressure, comes with cholesterol for most of our patient population, right? And it's very common. We used to call it the three amigos, right? Blood pressure, diabetes, and cholesterol. And so we knew that we were not just going to be addressing diabetes. So we created this program that provided food and disease management education at the point of contact with the patient, with tangible products in the patient choice. They come into our food pharmacy and they shop around. The disease management education was really rewarding, because, you know, most of our dietitians back in the day, and even our nurse patient educators, were spending a lot of time in their offices, right? So this gave opportunity for those folks to come out of their office into a setting and do that tangible education with our patients. But what is the long-term intervention? It's, you know, our patients enroll in the program, and I'll talk more about that in a second, but we also connect them to a navigator who helps with those long-term, you know, can we get you enrolled into SNAP? Can we get you enrolled into it? Can we get you enrolled? Like all of those other things that patients really struggle navigating through. And so, you know, I want you all to consider also too, some of the other kind of very important things. I mean, we could talk about this for days, but just very quickly, want to point out that as you're looking at instituting a food pharmacy in your clinics, is that you should consider the site, right? From the leadership to the patient population to the community. Is there heavy stigma where you will have to focus a lot of education on even just getting the buy-in, right? Assess for transportation, because when you're giving folks 30 pounds of food, you've got to consider, is everybody getting on that bus, or is everybody driving here, that we can make this easier for them? And I'm sorry, one thing with the stigma too was, our patients, are you going to send them out with just clear plastic bags that shows that they're getting food? Or do you want to put something in a bag that's, kind of, it's a nice bag, but no one knows what's in there? So something else to consider with the stigma. You've got to consider your staffing, the roles and responsibilities of your different teams. You've got to consider the permits, right? Because as a food pharmacy, we are food handling. As a healthcare setting, you're looking at infection control. I will tell you, back in 2018, when we were doing this, we were having to teach a lot of our teams as to what was important, for instance, in infection control with our infection control partners in a clinic. The other area is hours, right? Is your community, the working community, where you have to consider opening a little bit later and staying open a little bit later? Like, what does that look like? Deliveries from our Houston food banks. When do you have to be totally staffed up because the truck is coming? And then you have to consider the weight of that truck. I learned this. They're like, Hope, we can't bring this truck here because it weighs X amount of pounds. And so you're going to have to give me another driveway. And it's like, so it's those little things that sometimes we don't consider as we're thinking about really putting this into a clinic. And then last but not least, as part of your programming, the outreach. How are you going to enroll patients? Because yes, we are screening. Yes, we're giving a prescription, but the patient will walk out of the clinic sometimes. Or they come in for 2 visits and we lose them. So for those enrolled and not enrolled, we had to also put that piece in place about outreach. And so I'm going to tell you right now, this was not Harris Health doing everything out of our own brains. It was, again, lessons learned from all our national partners, research, and the Houston Food Bank holding our hand through a lot of this. So once you create the program, it's like, how do you get it into the home? And what you see here in front of you is an actual picture of our food pharmacy at Strawberry. I want to point this out, that what you see there are healthy products, because our goal was to not only address food insecurity, but also to bring in the nutrition security, right? So when you go to you go to a pantry out in the community, and mind you, we call our sites food pharmacies, but they're set up like pantries. But we don't have the chips, the cookies, and some of those unhealthy products that, we're trying to lead by example, right? And so that's why you see what you see here. And so part of the food pharmacy program and getting it into the home is those 30 pounds of food every 2 weeks, but it's also connecting our folks to some sort of tangible long-term solution. And so one of our partners here is also our LBJ community farm. So getting fresh items from the farm into our food pharmacy. And I have to tell you, when I first went to them, I was like, organic. But I learned a lot about organic. So different story for a different day. All right, so we get it to the patient. Then what? I went out to a patient family council meeting, and one of the community members told me, I go to the food pantry all the time, but I don't know what to do with the food. And so then when I went to go visit the pantries, because that's another piece that I did, multiple members of my team went to several food pantries, and you saw things like eggplants, because of course that's what's in season. And so what we decided was, like, we're going to have recipes, but what does that look like? And so we're so fortunate to have a collaboration and a partnership with UT School of Public Health, like Dr. Sharma, Melissa Dano, and others that helped us create these meals, these recipes that are inexpensive. They are applicable to our patient population living with diabetes. They taste good, they're culturally sensitive, and they are very quick. And so we've had many families say that, they're quick recipes. Back to the patient also included diabetes self-management education and prevention. So it was talking to our patients when they came in about, hey, how's your blood sugar? How's it going? And you learn that patients will tell you, well, I haven't checked it because I ran out of strips. Now, their visit was 2 months out with their provider. So what do you think was going to happen during that visit time, right? Like, they weren't going to be checking their sugar. So it's some of those opportunities where you can do some real-time education that the patient is expressing, and not just, us doing what we want to do. But we do touch on certain topics in a series, mostly because we want to make sure that the patients are walking out with something. But our main priority is to address their expressed immediate need. And this is just a kind of like an idea of what those topics look like, and how we structure different education topics through the months. And as you see here, we did January and July because we wanted the patient to hear the information twice at least. And so I'll move on to the next element of what we're talking about today, which is evaluation. With evaluation, it's really important. I've been in healthcare for a long time, and what I have seen some phenomenal programs go away because the evaluation piece was weak or non-existent. And what you see here in front of you as part of evaluation is data collection, right? We knew that part of evaluation was that we needed to create questions that we wanted answered about our program, right? Because we wanted to make sure that what we created was meeting the needs of our patient, but also with evaluation, it would help us to say, are you doing what you've set out to do? One of the key important pieces of evaluation is deciding, how are you going to gather this information? What instrument are you going to use? When are you going to collect data to help you answer your evaluation question? And then at the end, analyzing that data and giving the response, share those reports. And so what you see here is the evaluation, the data collection piece, and how we set a timeline and what we considered. I'll talk about this in a second more. So here it is. As part of the evaluation, this is what we created, right? Which is the outcomes. We looked at increasing consumption of fresh fruits and vegetables, right? Knowledge, that A1C control, the LDL control, the blood pressure reduction. Now, the process of the work that we're doing, right? The number of patients screened, prescribed. We were very, very intentional when we created this because, again, with the lens of with evaluation, we needed to answer the questions that we set out, right? Which was, is this program beneficial? Is it helping our patient population? And then more importantly, and sometimes what we forget is that evaluation, our scorecard, whatever metric we're using to monitor and measure our program, should be shared with our stakeholders, should be shared with our community. Good, bad, sometimes, what we learned that for our folks, that blood pressure reduction wasn't as significant as we wanted it to be, but that A1C reduction, A1Cs were reduced by 1% in this patient population. We weren't even changing medications or managing medications. It was simply providing this tangible food for our patients. And so when I say that, we need to report back out, it should be, what are we reporting? Who are we reporting it to and when? You want to make sure that you're going back to your clinics, to your providers and telling them, hey guys, the screening that we're doing, we're screening these many people a month or in a quarter, however you decide to do it, right? And then this is what's being expressed. Oh, and because we're handing out food and education, look at their A1Cs. Oh, but you know what? The blood pressure reduction is something to work on. Those are the things that clinicians want to see, not just, hey, we're screening for food insecurity, we'll talk to you later. So I really asked us to kind of spend time there. The other area that we screened was for patient satisfaction, right? And this is what we heard from our patients, and we continue to hear from our patients. Patients saying that the food pharmacy has helped control their A1Cs, right? Being able to understand, being able to appreciate learning how to cook better. In our culinary medicine piece, folks, I just heard this the other day, a patient saying is, I didn't think I could cook summer squash, but I learned how to do it. It was really easy and really fast, and now my family's eating that. And so those are the stories that are really meaningful, right? And then needless to say, many of you all here are experiencing the provider burnout, post-pandemic, and I get it. What we're getting from our patients is, from our providers is what you see here. The provider satisfaction is phenomenal, and they continue to express this, right? They continue to send their medical students to us. They continue to ask questions about what we're doing and appreciating what we do, right? With them and for them. A quick story, one of my physicians that I always share is that one of my physicians was like, Hope, I have a patient who is skimping on her insulin, and her diabetes is totally out of control. And so I was like, she can't afford her insulin. We can get her somewhere. But that wasn't the situation. The situation was that she was food insecure. She had 4 teenage boys that she was raising that as a grandmother, And really, she was skimping on her insulin because she was trying to save money for food so she can feed the kids. So he felt empowered to talk to her more about food insecurity and about the ramifications of her skimping with her medication, as well as the food insecurity, because he had something tangible and he saw what was going on with the rest of his patient population. And so I just want to share like where we're at right now as far as locations. We're currently at Strawberry, Acres Home, and LBJ. And I'll tell you that part of the continuous process improvement and quality improvement is us setting up sites strategically, right? So right now, when we went to Strawberry, we also saw that we had a transportation problem, as well as the food insecurity problem, as well as the nutrition problem based on our obesity rates. Acres Home, same thing. LBJ, medical desert, food desert, you name it. As we're looking at the rest of our centers, we're looking at, is there capacity? Is there space? Is there a bus stop? Is there not a bus stop? Like in every community, we are doing the constant performance improvement, process improvement to assess what model do we need to bring into this community, into this clinic, right? Is it a medical nutritional a program, right, that we provide food? Is it a partnership with our, another organization? Is it, partnering with another food pantry? Or do we need to bring that particular model into the clinic because we have space and we have this need? And so the key to success is that it takes a village. We have to start with, what do we see? What are we learning from our data? What are we learning from our patients? Are we listening to what our providers, to what our communities are saying? And then a committed, passionate team, because this is not easy work. The team who has been on this does this for the mission. And it's hard work, but it's work that we see has impacted our patients and that we hear. We see by those A1C changes. We hear by our patients express stories, and also our clinicians express stories. Our team in the food pharmacies doesn't just stop with the food distribution, education. They also play a role in care coordination. Hey, Mr. Galvan, I see that you haven't come in for your A1C. How can I help you? Connecting with those other members in our clinic to get our patients in and that access to care. Or, what we've learned sometimes is, well, my fat, is coming to run out and I don't know what to do. So there's so many different things that we're able to kind of do just in time with this program that I feel would probably not happen otherwise. And then last but not least is the robust community partnerships. We couldn't do this with our partners at UT Health and Houston Food Bank. When we first launched, Anthem supported us financially. USDA supported us and has given us many feedback on our different programs. So again, it takes a village. And with that, teamwork, right? You see here in front of you all the different members in the organization that had to have some sort of buy-in, some sort of support to be able to launch this work. From our population health team, our managers, our directors dealing with the everyday operations, our analysts helping us with reporting, the IT folks helping us build these best practice alerts, these flow sheets, these questions in our EPIC electronic medical record. Our physician champions, right, from Dr. Porter, who is actually one of the clinicians on site who launched this with us, who gave us the lessons learned, do better with, and our executive vice president ambulatory care services, Dr. Small, who helped us with this is the site. I support you, Hope. Go to SteadyGas, go here, go there, based on what you're telling me. Our nursing team that when we came to them said, screening's going to look like this, but it's your staff that's going to have to do this. Them getting that buy-in from them. Our operations folks telling them we need space. And then last but not least is also our data science team. But across all of this is also our community health workers, at Acres, at Strawberry, at LBJ, and across the system who help us support this, who do the heavy lifting, who do the patient engagement. And so I think for me, just to end, when we started our journey back in 2017 in addressing food insecurity, food insecurity was an issue, and we found support through our community partners, through the Clinton Foundation work that was happening, through Houston Food Bank and others that had this interest. But the pandemic brought this to light, the food insecurity piece, right? And more, the disparities that are out there. But it also exacerbated the extent of the food insecurity, nutrition insecurity issue. And I have to say that I'm excited because for the first time in half a century, many of us know that the White House has convened, the Biden-Harris administration has convened a summit on food insecurity, which hasn't happened since Richard Nixon was in office. But when they did it back then, it gave rise to WIC. It gave opportunities in what back then was known as food stamps, which now is SNAP. And I know that as a nation, we do have an ambitious national strategy to achieve the goal of ending hunger, right? Increasing healthy eating and physical activity. This is part of our, Americans Healthy by 2030. And one of the strategies is to expand food as medicine. Everyone in this webinar has a stake in this game, hence our presence here, right? So I ask us that when we're looking at how do you integrate a food pharmacy into clinical practice, that we also think about not only how are we doing this for our patients when they come into our clinics, but our role in advocacy at a local level, at a state level, at a national level, and to really work on those non-medical drivers of health that are really the root cause that come with the root, and I'm sorry, going back, just the solutions that address the root causes of these non-medical drivers of health, right? Like, what are those things that are leading us here? So I just have to say, I want to say thank you to everyone here today, but also to the Texas Non-Medical Drivers of Health Consortium for bringing us together, and hopefully we can learn from this today. Elaine, I'll hand it over to you.
Okay. Thanks so much, Hope. Do you want to pull down the slides and let's all, like anyone who's willing to, show your face. I picked up comments and questions in the chat, and I'm going to start with those. But when we run out of those, if there's still time and you have a question, raise your hand, or better yet, put it in the chat, and Jackie and I will keep watching the chat. So first question that came in asks about whether Harris Health staff can access these services, and if so, does it help with buy-in?
Yeah, that's a great question. And by the way, I have two key folks here on this webinar today, is Maria de la Cruz and Melissa Perdeau, manager and supervisor of the food pharmacies, first and foremost. So I have to tell you, that's been a question for us, and we are working on that. But here's the deal, right? At Harris Health, we have a robust wellness program. And there's a lot of other things that are happening with the wellness program through HR that don't necessarily are trickling down over here. But I will tell you, we don't say no to anyone. We don't. And our own staff is learning from this program. So I don't know if Maria or Melissa have anything else to add there, but we don't have that structured, but it's never going to be a denial. But I will say Harris Health has a wellness program that we work on that too.
Thanks. Next question. Let's talk about paying for this. Cindy put in a question about, did USDA fund this? Can you take us through, like, from the beginning, the various funding sources you have had? I think I know that it's self-sustaining now within the Harris Health budget, but can you talk about how you got it up and running and what it costs and that sort of thing?
Yeah, absolutely. So back when we started, and you saw one of my key partners was Anthem. Anthem came and worked with the Houston Food Bank because they wanted to collaborate together with food as medicine, right? That's when they were doing all that food as medicine work. And so there was a grant that they helped us, to kind of launch this. And that's how we started. But the Harris Health commitment was, you have community health workers that you're going to need for this. We already had the staff, so to speak, because we have, to some degree, we had the dietitian and the nurse patient educator that were already doing their role, but now is bringing them into the food pharmacy. That has changed though, because this has grown, and it's like we said, when we showed that the A1C changed, the support came more for, okay, we need staff in here, and other grants and other opportunities. One of the things that I mentioned in a recent visit was that this is free to the patient, but not free to the organization. And so again, going back to advocacy, it's up to us, right? That this is what we need to start showing, these clinical outcomes, to be able to tell the higher up in the federal government and whoever else that says we need funding. So I know I gave you more, but it was staff that we already had in place, opportunities for funding from Anthem and others, and then community-based organizations like HEB and others who also gave us money.
Great. Another question about are the dietitians or nutrition counselors on the floor, are they available when the patients are there, or is it another visit?
Yeah, so Melissa, do you want to talk a little bit about that? Because it's a combination of both.
Sure, yeah. So at our food pharmacies, we do have a registered dietitian and a nurse patient educator that work with our patients in the program. So they do rotate between the different sites so that they're there. So each individual is at a site at least once a week. They're there in person. So if the patient has a question that same day, they're there to answer it. But they also do outreach virtually, so either video visit, or if a patient is not as tech savvy or not able to get on video, they also do outreach via phone as well. So that patient will always have the opportunity to have touch points with the dietitian and patient educator. And we also plug that into our program as well and make sure we do active outreach by those individuals so that everybody has the opportunity to meet with them.
We'd like to add something to that. I'm sorry. So throughout the program, the patient was probably going to meet with the registered dietitian and nurse patient educator 2 to 3 times, depending on their A1C and where they are. And part of the initial assessment by our registered dietitian, the food pharmacy's registered dietitian, and the nurse patient educator is it someone that I need to follow as a registered dietitian, or can I hand it off to the registered dietitian at that site to follow this patient? So working in partnership with the RDs and the nurse patient educators at that clinic for continuous support, because once they graduate from the food pharmacy, we want to make sure that they're continuously meeting with their registered dietitian and the nurse patient educator at that location, at their medical home.
Thanks. A question from Rosie. How are you working with your partners and how are you modifying and changing everything that you're doing based on what you're learning?
Yeah, so that's a great question. So going back to how we report out, right? So our key partner is Houston Food Bank. And so some of it is in a structured way. So I'll give you a quick example. So we have a report. We show how many people we're targeting. We show outcomes that I showed you the scorecard. The other piece too is sometimes there's a, how do I say this? When we get food, we may not get everything that we want. So there's some quality improvement conversations that happen that it's part of the ongoing stakeholder, meetings, collaboration. So it's that constant checking in with them. It's not, I mean, they're our best friends, as well as, our clinics that help us keep up with, like, how can we do this better on a regular basis? But it's really through communication and that report that we share with them regularly.
Kind of a related question from Lisa. How do you retain patient engagement and what is your retention?
Yeah, so I'm going to give you my 2 cents, right? I would love for us to be able to measure some sort of patient activation, right? And that would be key in retention, first and foremost. But there's been barriers to that we can talk in a different webinar. But that said, part of our quality process has been, okay, how many times does it really take for this patient to come in before we see this A1C change and it's sustained? So we went from 9 visits, right, that they had to come in, or 12 visits, whatever it was at the very beginning, and reduced it to 5 because we saw that, hey, at about the 5th visit, this person's A1C is changing. They're coming every 2 weeks, and then we see them again, and it's being sustained. So 2 things. We look at our program to make sure that we're not asking more of our patients than needed, 1. 2 is retention, like everything else, is a challenge. I think what I see and what I hear is that the patients, once they've seen that they've learned these things and their A1Cs are improving, they will check out. But we do have a process in place to do some outreach, right? For those patients that still have high A1Cs, and if we're kind of losing them, we have a little algorithm that says, okay, call Mr. Galvan. If he's not answering, call again. If he's still not answering, we're going to send him a letter, kind of like that process, so to speak. So we can try to do that, keep them engaged. But in all honesty, when we set up these food pharmacies, we don't have them in a back room. We have them where they're visible, right? We give that optic about why nutrition is important when they walk into the clinic. So I think that helps too, but something to consider. I hope I answered that question.
We have a question from Latasha about whether this is available just to your Harris Health patients. Or whether they can refer community members to you. Delighted to see the interest. I think I know the answer to that. But before Hope answers that, one of the things we're trying to do with this Texas consortium is connect people to various programs so that people learn what's going on in their communities and how you either figure out how to do it yourself or get someone in a program. So with that, Hope, go ahead and talk about whether this is just for your patients.
Yeah, so part, again, part of us learning about how we needed to establish this model was reaching out to, like I mentioned earlier, to other organizations who had been doing this for a while. And one of the things that they said was, you're going to have to show integrity for your program. You're going to have some sort of control, right? Because otherwise, it's going to be another feel good and it's going to go away, Hope. I heard this over and over. And so hence, that's why we went to a patient population. And mind you, it's in the literature. There's an article in 2019 that Dr. Sigelman and Dr. Berkowitz and others and the Houston Food Bank published saying that, they created the same kind of model, but because these patients had outside PCPs, primary care physicians, it was not sustained because they were having to rely on the patients for A1Cs and all of these things. So we closed it off to our patient population because of that, right? For that sense of control and to be able to show that, hey, this works. I will tell you though, that as we're evaluating our different programs and our work, it's a question to be asked. But we still have to consider like how much, that patient, we want to see their biometric outcomes. And so we have to figure that out. But right now it is for our Harris Health patients.
Got a question from Barb. What has been the positive and negative feedback from physicians so far?
Yeah, I think the positive has been very much what I expressed, which is, they have something tangible and they feel empowered, and it's been studied, right? Us as clinicians, as nurses, as doctors, we're not going to ask a question if we don't feel empowered and if we don't feel like we have a tangible resource, right? I think that the positive has been, their engagement, right? The negative, I haven't heard the negative. And I don't know if Maria or Melissa want to add to that, but yeah, I haven't heard the negative. At least it hasn't trickled down to me.
And there's no major negatives. I think that because we have a risk stratified, the patients either is first link or food RX, meaning if they don't have that A1C of 7% or higher, they are going to just get that one time and then that connection to the community through the Houston Food Bank CAP Navigator. Some providers just would like that all patients got the 18 visits, but it has to do with our capacity and our ability and the fact that we're wanting to see these outcomes.
We have a question from Godalia. We know that part of food insecurity is affordability. Have you reached out to Aldi Foods about partnerships?
No, we haven't. Honestly, whoever can make the connection on this call, I'd greatly appreciate it because I need all the help we can get.
We don't, and I would love that contact as well. If you can send it to Hope and I. We do part of the curriculum while they're working towards graduation, that 18 visit is how to shop on a budget. So finding grocery stores and like using what you can. So things like if there's an Aldi in that community that's nearby that home, the CHW, the community health worker might bring that up in that shopping on a budget, but it's not a specific partnership. So we will take it if you have it.
Okay, I think I've lost count in the chat. So many people put in questions. If somebody's got a question or a comment, Shout it out because I must have missed it.
Thank you. Good to see you, by the way.
Hi, Chris.
So I love the work you're doing. This is fantastic. Kind of several questions. Number one, are you sharing throughout the ecosystem of Houston with other health systems your work, and are you collaborating with them in a similar way? This is not just a Harris Health issue. This is every system needs to be engaged with that. And the other, you mentioned, your commercial market is not that high, but representing employers, they think they're immune from this and they are anything but. So I don't know how you're specifically working with the commercial payers to get this word out. And then last, and I'll provide this to Elaine, this is again, from a community perspective, there is a Health Benefits Nation is having a program in Houston from the 26th, from the 28th, and the third day is devoted specifically to food as medicine to combat diet-related diseases. I can provide that information to Elaine, and she can distribute if folks want to get involved with that. So and then the last thing, I am aware that UTMB has received a large grant from DSHS, Department of State Health Services, to offer the National Diabetes Prevention Program at no cost. I don't know if that's something that you're connected to, that you can generate these cohorts on diabetes control. So just a few comments, but great work that you're doing.
Thank you.
Thanks. We have a last question from Enrique, and it has to do with whether the food has been recalled and if there have been issues with that and how you deal with it.
So I hope I understand this correctly. So as part of our program is that we have to have permits, and our staff is certified in food handling. And so when the food comes in, we always have to check it. And so, and I hope I'm answering this, but we have a process in place for that. We haven't been involved in recalls, but again, this is one of the key pieces with the Houston Food Bank, as they're the ones who supply us, and then also too with the local folks that we purchase through.
Thanks. Time's about up. Thank you so much, Hope, and your colleagues for sharing this. I think it's raised a lot of questions and hopefully generated a lot of enthusiasm. One quick note from the Texas Consortium: if you go to our website now, which is driversofhealthtx.org, our program index went live about an hour ago. It's only got 25 programs in it because we had some friends who beta tested with us, but we are ready to populate that thing. And we know across the state there are hundreds of programs, and we really want everyone to check it out. And if you're involved in any kind of an NMDOH program, from a healthcare setting, we want to know about it, and we want to include it in our database, because that's how we'll all know who's doing what across the state, and we'll be able to learn from each other and teach each other and really grow this field of practice. So thanks again, everyone, for being with us today. Comments, questions, welcome. Email Jackie, email me. We want to know what you want to learn, because we want to keep producing content that is of meaning to the people who are out there doing the work in the field. So thanks so much.
Can you all email out the link? I wasn't able to capture it, Elena and Jackie.
Yeah, it's driversofhealthtx.org.
Okay, perfect. Thank you.
Thanks, Klaus. Good to see you.
Good to see you. Take care.
Good. All right, just us? Is
Almost.
everybody?
I think
Oh,
I think some folks are still trickling out.
okay. You can exit them.
Oh, I can.
Yeah.
Um,
Some people may have left their desks and not realized that we closed.
Oh, I didn't mean to do that. Okay, sent them to the waiting room. Hold on, Hope just called me. Hi. Hi, Hope. I know I saw, it said your last name. How are you? Do you wanna hop back on the link? Elena and I are still in here. That would be, yeah, we can do it together. It was great, by the way, but see you in a second. Bye. Hold on, let me stop recording.
Yeah, and those people